Let your curiosity rise.
Mad Bricks webcast,
Where the human spirit flies. Mad Bricks webcast. Where the human spirit flies.
Hey, welcome to the MedBix webcast live from Silicon Valley. Thank you for joining, all of you. It's a little bit of still a lot of light in Silicon Valley now. So it's a lot of things going on in Silicon Valley, and I'm going to tell you a little bit about that. They let me introduce you. Oh yeah, let me introduce you the two beautiful women. One first, let me introduce you my co-host. Then I will go to the next one. Let me introduce you, brilliant, bold, beautiful Susan Tall, 6 foot tall or 7 foot, I think she said. So she's a Susan Davis. Welcome, Susan.
You're such a weirdo, Ramana. I'm not 7 foot tall.
Yeah, Susan.
And you almost forgot me. Like, oh yeah, I've got to introduce Susan. What's going on?
Yeah. So, actually, there are a lot of things happening this week. Last week, I attended a meeting in, quantum physics Nobel Prize winner. I went to here is a very, one of the good things in Silicon Valley is a lot of action going on here. It is so much to pick up. Today, actually, Apple Developers Conference, I was invited there and I didn't go, but I may drop by tomorrow. But there is a lot of action going on here. One of the things I attended in a Stanford Research Institute called CSRI. Attended the quantum physics Nobel Prize winner last year. He won the Nobel Prize in quantum physics. I created an image up there. Navya, can you put that image to me? You can bring that, the picture that I took with that gentleman. No, not that one. The other one. That's my nephew. There is another one. Yes. He's the tallest guy. He's a 7 foot tall.
Now that guy's 7 feet tall.
Yeah, he's 7 foot tall. He's almost touching the ceiling. Yeah. His name is John Martinis, John Martini and Margarita. What a combo this is. His name is Dr. John Martini. What he did was quantum physics, the electron could be in particle, could be in multiple places at the same time, or multiple. That is one of the quantum physics strange phenomena. But what he said was that's only particles, like a very, very minute size, electrons, protons, neutrons, those are the size particles, micro particles. That is a micro world. But what she proved is interesting. You can do that. That could be macro world, can be multiple places at the same time. Eventually, Susan could be in Florida and Silicon Valley, in New York at the same time. That it is what he proved. It's a very interesting. I had a wonderful privilege to.
Wouldn't that be something to see? That would be something to see, Ramana. It's hard enough to get people to understand in the micro world, but saying that it's in the macro world as well, that'd be a trick. That's pretty interesting. Then
Apple World is coming here. But let me introduce you without further ado. Take it out that image. That you don't need that image. No, they take it out. That's my nephew from Calgary. I don't know.
My nephew from Calgary.
He's my nephew from Calgary, Canada.
He's tall also.
He's tall, yeah. He is except the midget from my family. I'm a midget. My son is tall too. But let me, I tell you, I have a wonderful privilege to invite one of the guests of ours. She is really a trailblazer. Do you like margaritas, Susan?
Yeah.
Yeah, I do. Who doesn't love margaritas? So she has a name inside, middle name. She got that one. So let me introduce you. Good evening, everybody. MedBix webcast, where medicine meets technology and Silicon Valley innovation. Our guest tonight is Dr. Margarita Ochoa-Maya, MD, a Harvard-trained endocrinologist, physician executive, educator, and a digital health innovator. Throughout her distinguished career, she has worked across multiple fields. She has worked across clinical medicine, academia, biotechnology, and healthcare leadership, helping bridge the gap between the patient care and the emerging technologies. Dr. Ochoa-Maya, that's a beautiful name, has held senior leadership positions in endocrinology, rare disease, digital therapeutics, and medical affairs. While
Woo!
championing the use of real world evidence, I want to understand. I heard first time real world evidence word itself, health information technology and AI driven solutions. Yeah, AI. Here is a. I'm in Silicon Valley. Even the Uber driver talks about AI here to improve patients' outcomes. She's also an active member of the Scale AI Healthcare AI Forum, contributing to important conversations about the future of healthcare transformations. Tonight, we will explore AI in healthcare, digital health innovation, rare disease management, health equity. That's my favorite field, and I'm also presenting some topic about that, and the opportunities and challenges facing modern medicine. Welcome, Dr. Margarita Maya Ochoa-Maya.
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 Woo!
Welcome,
Hi.
welcome,
It's so
welcome.
wonderful to be your in your show today. Thank you so much for inviting me, Susan and Ramana. Thank you
Oh,
very much.
so much fun. My goodness, the
It,
depth and breadth of your experience. Who knows where this conversation is going to go
it
this
is.
evening?
We'll
Yeah,
have a
it
lot
is
of
a.
fun.
It is
Yeah.
truly an honor. Did I miss anything in my introduction? If you want me, you want to cover that up a little bit. Where you from? Where do you from originally? I mean, you're
Yes,
born. Yeah, you're born
yes.
here.
The beautiful thing is I'm a human like everyone else. But yes, I would like to start with I am originally from Colombia, South America, and I came to the U.S. For my medical school training. I did my medical school in Colombia, and I graduated, and then I did my residency and fellowship, and lived in Boston for the majority of my adult life until most recently I moved to Florida.
Okay. Oh, interesting. So, let me ask you, that this is one of the, you're one of the, I know Scale AI a little bit. I heard about it, people talk about here in Silicon Valley a little bit about that. Scale AI produced a lot of labeling data for a lot of that's a really engine feel for the LLMs and all the engines, right? Scale AI does that. I met a couple of people from Scale AI, I remember. So tell me, what is your contribution for that kind of a thing, what you're doing for understanding the clinical medicine. Before I do, one thing I wanted to ask you, I'm in Silicon Valley. The Palo Alto is a few miles from here, and then we are the Facebook, LinkedIn, all of them, the major company. Google is a few blocks away, but still there is a huge gap between the healthcare and the medicine. That's a huge gap. You talk about it quite eloquently about that. That talk about that gap, and then talk about what you're doing in this direction.
Yes. So to answer your question specifically, Scale AI has been kind of powering the backbone, powering the entire artificial intelligence revolution. So while companies like OpenAI and Google and Meta have built the frontier models, Scale AI is the company they're all hiring to clean, label, test, and tune the data that makes those models smart. So the way that I work as part of the community is that they send me some questions in endocrinology, and then we make sure that the answers are relevant and sourced properly. And in that regard, we are kind of training their algorithms through some scientific backbone and data. So I think their effort is to make sure that we are all kind of continuing to have that human input to ensure that their artificial intelligence and their algorithms are trustworthy and fundamentally based on science. Did I answer your question, Ramana?
Oh,
Is that what you
absolutely.
mean? Is that what you mean by real world evidence? I mean, it doesn't get much more real world than that, right? Bringing a physician who is in an endocrinology as a specialist, and now you're helping training the models in endocrinology. That seems pretty real world, yeah?
Right. And then, but real world evidence is also a new term, which isn't really new, but it's a term in which we have the evidence that we do when we do clinical trials, when we do scientific evidence, we use kind of a very curated group of patients. We have inclusion and exclusion criteria. So what happens is we use that curated concept to really study the efficacy of a drug, for example. But then we take that to the FDA. What ends up happening with real world is that once the FDA approves an intervention, a medication, it really goes into the real world. It's not curated in the sense that you have that very structured inclusion and exclusion criteria. The patients that have the need might have other diseases, other conditions. And so real world evidence in that regard is really looking at it, how it really performs in the real world in the community. But you're right. Real world is really kind of bringing that artificial world out, right? And bringing that use case scenario. So when we think of AI, when we think about how it is transforming healthcare, we really want to make sure that we keep that heart at the authenticity of what, the different things that can happen in the real world are not artificial. Anything can happen in the real world. So when we think real world is that anything can happen. And Ramana, you were talking about quantum physics and quantum entanglement. That's when it comes that when you know something very well, you then realize you know nothing. So it's an avid concept of continuously learning.
Talking about war, one second, Susan. Talking about war, you're from Hispanic origin, I'm from India. There is the diseases manifest, particularly diabetes, manifest in different forms in the cultural backgrounds. You got to have understanding. The answers must be relevant. If you tell me I'm a South Indian, if I tell me don't eat rice, that is no, that I don't pay attention to you. That's okay with me. I'll die faster. So that kind of a thinking, it is very important in the cultural aspects of including in the dealing with the patients, right? What is your take on it?
I think the real world is, again, when we think of the ocean, the vast ocean, and that we know a little bit, but there's so much yet to learn. And in the real world, when we think these curated concepts to bring scientific evidence, the reality is that we have to really look at how the environment modifies our daily living. And in this case, culture. It could be the food. It could be the appropriateness of, culturally sensitive meals. So I think ultimately one of the things I talk a lot about is the social determinants of health, of realizing kind of where we have to come to the patient where the patient is at. And we constantly bring in science, we have to ask the patient to come to where we're at. And you brought a great example. Like in Latino communities, we do have a lot of carbohydrates as well. And so telling a patient not to have, rice or beans when that is the main staple of their meal is definitely artificial. And so being in the real world is realizing that we have to have cultural sensitivity with every intervention we have, for sure.
Yeah, absolutely. Good answer. So, let me ask you, the medicines are being developed, the drugs being developed in that context, or just simply they take a bunch of Susans and developing medicines there. What is that? What is the situation there? And then how we are going to change that kind of understanding?
Well, I love what you bring, because ultimately, particularly even when we think about rare disease, so when something is very common and very prevalent, it's somewhat easier to study. But in rare disease, you have maybe some situations that don't happen for months. So when we're doing scientific studies, one of the solutions that has become more evident as we have digital transformation upon us is that we can use decentralized trials. So to some degree, again, it's not like the patient comes to us, we can come to the patient. So yes, we want to include in scientific trials as much diversity as possible, but not always is it really realistic from a logistics point of view. So, we have to do what we can with what we got, but the ideal circumstance would be to have a very diverse population in every scientific study we actually conduct.
So you talked about a couple things. Ramana brought up the obvious. I don't want to say obvious because I'm not a hater on diabetes. It's just an obvious conversation when you're talking about endocrinology, but not quite so obvious and maybe not a rare disease. But what about thyroid disease? I know this is an area you work a lot in, but who loves on the thyroid? I think you do. But is it a rare disease? Do more of us have it than we know about? Who is talking about the thyroid?
Yes. So the thyroid disease is definitely in the scope of the endocrinologist. But the truth is, the thyroid disease is actually the gland thyroid is really in the neck area. So sometimes for anybody watching, when you look at someone in the neck, if it's actually a pretty swollen, that's where the thyroid could be. And it can be overactive or underactive. An underactive thyroid is actually pretty common. And it's very common in women. Far more women than men have thyroid disease in general. And hypothyroidism is common. It usually is manifested with an underactive thyroid, meaning you're like sluggish, you're a little slow, you can gain some weight, your heart rate might be down. But the contrary to that is hyperthyroidism, or an overactive thyroid. And that usually happens where your metabolism is sped up and your heart rate is up, you're sweating a lot, you might even affect your eyes, and that causes thyroid eye disease. And so yes, that is not as common, and usually when it manifests, it makes the patient very, very, very sick. So it usually goes in the purview of an endocrinologist to evaluate that patient. Yes.
So you brought up something very interesting. I don't know if in my nursing career, I've even heard of thyroid eye disease. I don't remember even hearing about that. And now I just recently saw there's some pretty cool innovations with AI and thyroid eye disease, as far as being able to help monitor patients. I mean, there is no end to how cool AI is getting. So that's my one question. Are you familiar with any of these new AI thyroid eye things, as well as, aren't the foods, I'm two questions here, but thyroid foods are kind of weird foods, right? They're not, I think they're all
iodine
rich foods. So, and they probably would help our eyes, but tell us about AI and how it's helping thyroid eye disease.
So yeah, so again, we were talking about the story in terms of kind of keeping the line here is hyperthyroidism and overactive thyroid can be caused by an autoimmune attack against your thyroid. And so usually it's an immunologic condition. And what it does is it kind of turns on that thyroid to produce more thyroid hormone, which turns on a lot of things in your body, including losing hair and, getting really skinny. But there's also a secondary condition in which the autoimmune attack happens in the back of the eye. And that, in terms of our eyes, we have like a bony structure that is fixed. So as things start kind of fizzing in the back of the eye, the muscles start becoming bigger and the fat tissues start kind of growing, it pushes the eyes out.
Oh, exophthalmos. Okay, right. Wait a minute. I got this right in a test a long time ago.
Yes. And now, it's been a long time that, there was not a lot of medications that were able to be treated. Usually patients were treated with steroids. But in the advent of newer medications, there have been newer treatments that really benefit these patients. And to be honest, that exophthalmos, which is the medical term of also proptosis, or the eyes bulging out, it's very disfiguring. And as the eyes bulge out, the binocular vision, or the ability to focus two eyes together in one way, you start having double vision. Yikes. And with double vision, you can only imagine it impacts the ability to drive. It impacts your ability to look at a screen. It impacts your face, and a lot of isolation happens. So on one end, your day-to-day activities, like maybe even taking a bath and the risk of falling and breaking something, all the way to being able to go to or from work using a car, or riding a bicycle, or even walking if the floor is being wavy. And then lastly, that is impacting your day-to-day activities, but then it starts impacting your appearance. And, some people might even think this is cosmetic, but no, what it really is disfiguring. The patient might feel anxious, might feel very self-conscious, and then they start isolating. And as there's isolating, they kind of really need caregivers to take them to their appointments and things like that. But then there's that economic impact. They might lose their job. And if you lose your job, you might lose your insurance. And so really, this is a devastating disease that we do not want to take lightly, for sure.
Yeah.
Dr. Maya, the Silicon Valley is doing a lot of advances in eye vision, computer vision, that they're doing a lot of retina studies. Are you familiar with that situation? Where,
for sure,
give some light on that one. See where we are at.
Yes, I recently joined Thyroscope as their medical advisor. And so, yes, there's a lot of beautiful things that technology is helping us evolve in. Number one, how we identify the disease, how we then diagnose it, how we then treat it, and then ultimately how we monitor it beyond treatment. So what we have had so far until just recently, or really the gold standard still today, is using a tool that sits on the base of your kind of your cheekbones and measures the angle of how protruded your eye is. But using, digital technologies, maybe taking a picture or a selfie, or even at the office having a solution where you can take, the doctor can take a picture of your eyes. They can use digital transformation to be more accurate in their measurements and to have a consistent measure over time so that you can monitor the patient's progress. So yes, a lot of innovation is happening. And I'm sure that although I mentioned Theroscope, there might be other companies that are doing similar research.
Awesome.
Yeah, well, let me ask you. India is bursting with the diabetes everywhere. It's a very new phenomenon here, particularly in India and China, and those countries never had before. All of a sudden, we are onslaught of disease, diabetes, coming into India and other countries. Is it happening all over the world, or just certain countries like computer kind of guys who sitting down there in computers? What is this? Yeah, did you find a phenomena that is correlation with anything like that?
For sure. And we're also seeing it in Latin America as well. So a couple things come to play here. As a matter of fact, the American Diabetes Association meeting is just wrapping up. And there's a lot of discussion around that incidence of kind of how diabetes, as in the US, we're being able to tailor it and kind of put a little control on the epidemic. But we are seeing this kind of really increased rates of diabetes in countries like India, or where I come from in Colombia. And then you ask me why. Well, there's multi factors for that. But a sedentary lifestyle, we are all, since COVID came about, we are all being very much glued to our computers, and physical activity is coming down. And again, even in exercise, one thing is kind of cardiovascular and the other one's building muscle, or the term lack of muscle sarcopenia. So on many aspects, we talk about physical activity, we talk about the consumption of food, and then ultimately, what this food is consisting of, right? And so carbohydrates, proteins, fat, fiber. And another very beautiful topic would be the microbiome, the bugs and the healthy bugs versus the unhealthy bugs. And so obesity is indeed becoming a clear problem in countries that are kind of in like India or Colombia. And what we need to do is scale education relative to the intake of food, the exercise, and then what our biome is doing. But then ultimately we are diagnosing more of it. And then what can we do to treat it? And with the advent of GLP-1 and the progress there, and even with the now most recently the pill, I think that these medications are becoming more affordable, more accessible. And so ultimately, what is first, the chicken or the egg? It's preventing the problem to begin with, but then also being able to treat it sooner rather than later.
So, Dr. Margarita, that goes right into my question. I was going to ask about the GLPs. And I mean, I'm only familiar with usage here in the United States. And I know that the PO opportunity is starting to climb like crazy. But what is that usage like in India or in Colombia? I mean, are the GLPs as popular globally as are they here in the United States? And are they accessible, affordable?
Exactly. So are they good? Are they good to start with? But is that a blanket statement? Is it automatically works for everybody?
Don't forget what they were created for. They weren't created for what they're being used for right now, primarily. But I'll let the experts speak about it.
Yeah, for sure. There's so many important topics right there. So number one, of course, we always take our medication to the FDA, and so the FDA has to prove its benefit beyond the status quo, that is safe and effective, but it's within the intended use. So that is very much a concept there in terms of like using it for the appropriate reasons. And then ultimately educating the patient properly if they have access to the medication. I'll get that back to you on that one. But if you are taking the medication, it's not then a permission to go have your fast food, right? It's actually take the medication and then still continue your lifestyle modification, mainly making sure that your diet has good fiber, good protein, and then ultimately you don't lose a lot of muscle mass. So again, with the GLP-1s, we're realizing that maybe there is some use case scenarios where you might have too much of it, right? Mm-hmm. And so to some degree, I think it's appropriate diagnosis, appropriate onboarding, education, knowing how to use it, knowing when to stop it. And that is an active topic of conversation in scientific forums today. Now, you did mention one thing, is that because there are multiple companies working in the GLP-1 space, the molecule itself is evolving. We have next generation GLP-1s. And then to that effect, by having more products on the market, as usual, I'm not a economist here, but more products might bring the price down, making it more affordable. And then lastly, the introduction of novel meds, like even the pill itself, which might be a barrier for some people who don't want to use syringes or shots. But it's a rollout. So we are hoping to see that the pill will be available in all countries all over the world, but there might be some areas in which it's not available yet.
Very interesting. Let me just say, did you talk? You have a question?
No. I really go on and on GLPs, and there's all kinds of varying. I think, look, Romana, some people are haters because they don't understand and or aren't exposed enough to its original purpose, how well it works. I mean, there is no magic pill. Dr. Margarita gave 100 reasons of what people still need to do to care for their health when they're taking them. The muscle loss and the diet and still movement and still sleep and still take care of your mental health and all these other things. So anyway, I'll get off of the GLP. Go ahead, Romana.
Let me ask you, Dr. Marty Macri was the FDA commissioner. He just moved out, but he was a great author. He's Johns Hopkins. He wrote a book, and you tried in the Amgen. You went through a drug all the way to you went through the whole process of FDA regulation. What is that journey looks like, taking the drug through the FDA?
Wow. To close the subject on even the GLP-1 use, I think with digital transformation, with wearables, with ways in which the patient can monitor their progress, that's going to make a lot of beautiful changes in helping patients, get to their successful goals sooner. But now you talk to me about the journey. I think it's important to talk about different journeys, right? We have the patient journey in terms of kind of how they identify the disease, whichever that disease would be, and how they're like, well, I think this is not good. I want to talk to my doctor about it. They talk to the doctor. The doctor may or may not identify that disease and then may make a referral to a specialist and whatnot. There's the disease journey, is what happens if the disease goes unchecked, untreated. And so you might have a situation and you can't go to the doctor, you don't know to go to the doctor, or you go to the doctor and the doctor doesn't really know what you're talking about. And it might take a long time. There's a disease called acromegaly, or a very excessive amount of growth hormone. And because our bones are already closed, the patient can actually grow, but their features grow, their hands grow, but it takes maybe sometimes up to 20 years to get the right diagnosis.
Wow.
So it's a matter of, again, learning, and the patient learning how to identify their own symptoms and what they're presenting, how they can tell the story or their complaints to the doctor, and then ultimately the doctor fully understanding what the patient's talking about. Now, Romana, you talked about like the journey of a drug development, what comes with what's called phase 1, phase 2, phase 3. So, usually when we start thinking of, like, let's say GLP-1, it started at the lab, in an observation, and they started realizing, wow, this molecule does this work, and then they have to do a lot of work maybe sometimes in animals and in the laboratory environment, and then they bring it to first in human. That is a huge leap, right? So then now it's like, okay, now we're going to experiment with humans, and there's a lot of regulation around that. And then it's a few humans at first, and then you start growing the case to a lot of humans. That would be like a phase 3.
Real world humans?
Not yet.
Oh.
Even though it's almost real world, but it's in this case where it's before the FDA. So you have to show to the FDA that not only did you try it in 2 humans, you tried it in a good amount of humans that are suitable number for the FDA to feel comfortable. Then the FDA gives it the seal of approval. That takes a lot of time. Again, digital and AI has helped a little bit. And we saw how the COVID vaccine got developed kind of quickly. But ultimately, it takes between, 5 years to up to 10 years, so it takes, and then not to mention the amount of money that really it costs to really invest in innovation. But once the FDA is approved, or we get an approval from the FDA, now we talk about educating doctors, rolling it out, showing how to do it. And that's where the real world comes into play, because it's at first done in kind of curated environments with inclusion criteria and exclusion criteria. But when it comes to the real world, it's all bets are off. And so
the gates are open. What? The barn doors open, the horses are out.
For example, it's more like, okay, so what happens if it's in the people of color, or what happens if you're a little older, or what happens if you are of childbearing age and potentially you could get pregnant? These are areas in which we have to be very strict to follow the guidance of what the FDA says. So, for example, you can't get pregnant on this medication. You absolutely, as a doctor, need to advise the patient that they cannot get pregnant on the medication. And Susan, it can happen. And so what happens when that happens, right? And so these are the things that, right. Yeah. This is where real world gets a little important. And that's why, communicating with your doctor, and even the FDA has outlets, and, we all are communicating in the scientific community to ensure, first of all, that the patients are safe. And secondly, that the intended use is causing the proper efficacy, or that it's doing the job. Did I answer your question, Roman?
Yeah. Let me ask you different digital therapeutics, digital thing. When I was growing up in India, to get a phone call to phone line, it used to take 5 years. All of a sudden, the wireless phones came in, and it's a quantum jump, and a billion people have the phones now in India. It is a big transformation, quantum jump. So, do you see that kind of a transformation because of that quantum jump that for the healthcare? So you can do wearables, you can monitor them from home. Is it going to transfer? We're going to transforming the healthcare into the other worlds that we were lacking before all these facilities. You think you're going to transfer that into the next level of advanced care?
Absolutely. This is a beautiful point. I mean, I couldn't be more passionate about that, especially because in the field that I work in endocrinology, there's a shortage of endocrinologists.
Yeah.
And if we use kind of a mathematical kind of scale, this is not an accurate number, but there's, maybe under 4,000 endocrinologists in the US right now to treat about a disease. Let's say if it's obesity, 38 million people have it, right? Wow. So the average wait for an endocrinologist can be 8 months to a year.
Yeah.
Oh my
so God. With that, you mentioned the access to wearables or access to AI in general. We see also patients, and they're a little dissatisfied with healthcare, maybe not a little, but at the same time, it's more that there's a burnout, right? There's a burnout. There's not enough time. There's not enough doctors. The patients have a lot of questions. So then from a patient perspective, they're going to AI to ask questions. But we don't want our patients to feel that they need to be doctors. The other way around, we want to create efficient workflows to create, a loosening of that bottleneck, right? And so I think digital transformation and understanding the journey and knowing where the next level of digital changes is in creating efficient workflows to have the ability to take care of these patients sooner, focus on prevention and education at the best that they can do, and ultimately empower the patient to take responsibility for the things they need to be doing, so that it becomes a true partnership between the doctor or the provider, the patient, the community, and the health system as a whole. Oh. That's the future North Star.
And that was so well said, very well rounded. And I'm gonna throw in there, but there's gonna be a huge part of this deal, of that cycle, that health literacy is gonna play a huge part. So here we are, digital literacy plays a part, and so we want them to quantum leap, like Romana just suggested. But in order to do so, there's a lot of that education. There's a lot of learning. And outside of just, used to be whatever, Dr. Google, and now it's, oh my goodness, the AI. The AI running the world. So what can we expect for health literacy as we're moving home? One of our guests here recently just said that the largest hospital in the world is home. So we know that they're there. What are we going to do, Dr. Margarita?
Yeah.
Romana, you wanted to say something before I?
Yeah, no, no, no. Just go ahead to complete it. Yeah.
To me, I think ultimately it's bringing the heart to medicine using digital transformation. And how do we do that? Is we have access to, for example, in the US, zip codes. And one of the themes that my colleagues in the digital space, my friends, have always heard me talk is bringing the heart to medicine by bringing social determinants of health. We have been asking the patient to come to us for as long as I've been in medicine and before. I think we have the possibility through the explosion of having cell phones in the hands of patients, which we did see with hope that even the older people adopted cell phones, but even at a rate that we were not expecting with COVID. And so the access to the cell phones is better every time. I mean, we still have work to do, but also it's through that we can come to you. These wearables are evolving into a space in which the wearable is no longer just telling you things that scare you, but helping alert you and connect you with your doctor. So, in a way, kind of bridging that gap between the patient and the doctor by doing work that can be busy work, and then having that ability to bring that relationship back between the doctor and the patient.
Beautiful. Talking about social determinants and health equity, I'm going to tell a story just to remind you. We all may know about him, but let me bring you on the side, and we can talk about when you get back your experience of health equity. That is the one you can do. You know that this is a story of an extraordinary man. I'm going to talk about that. You know, modern plasma. Whenever anybody goes to the blood transfusion to the ER, emergency room, or you know that they vow to this man, that they, you know, blood transfusion is, they vow to this extraordinary human being. I tell you about the story of him. He changed the modern day plasma medicine. Begins here with him. You know, he was before the Second World War. The people, soldiers, used to die on the battlefields, lack of blood. And then people, before they go to hospital, they in the accidents, they used to die. So this is a change. He changed the entire world of that industry. That absolutely saved lives. His name is, you know, he is a modern day, you know, that his name is Dr. Charles Drew. He is from he is the father of the blood banking and the American Red Cross. And you know, he actually started the the blood banks. You know, Red Cross, American Red Cross blood bank. He's a modern day pioneer in the blood banking. And he is the one started this whole thing about the blood transfusion and the plasma separation and all those things. He's really, as not only as a scientist, is a leader, is a remarkable human being. Let me tell you about him, a little bit more about him. He was born in 1904 in Washington D.C. You know, his father is a contractor, construction contractor. Mother is a school teacher. Excellent combination. You know, that Charles Drew applied for you know, he was born in a very modest family in the segregated world of Washington D.C. And then he attended a school, high school, Dunbar High School. Actually, it's called Dunbar High School. It's one of the well-known high schools among the black communities. He attended that school. So he was excellent in he was excelled in the actually he was excelled in the athletics. He was very good in academics. And also he is very good basketball, baseball, and football. He was playing all of them. He was excelling in all those directions. So he was a meant to be hero. So he could not get a secure seat, medical seat in the United States because of segregated laws. And then what he did was he decided to go to Montreal, Canada, as we were talking about in Montreal a few minutes ago. He attended at McGill University, where I lived in Montreal, and I went to school right across McGill, Concordia, actually. But he went to Montreal, McGill University. He studied a MD there. That's where he excelled really. He saw a different world, a different understanding of the racial problems and other things. It is a really different lens he went through in Canada. Is a less effective, you know, up there. So he was a very much into the McGill University, where he met actually British professor John Beatty. His name is John Beatty. He was doing a blood chemistry. He was working on the blood preservations. He's doing a lot of scientific work. He's a scientific papers he's doing. He took under his wings Charles Drew was his student. He became his mentor. The John Beatty from England. He is an English professor on a sabbatical. He was in McGill University. He really that relationship played a pivotal role in the future. I'm going to tell you, man. But then Charles Drew did a surgery in the Montreal General Hospital. He got the MD there, and he moved back to the United States after that. So he went to the United States. Then he went back to he practiced it for a while, I think. Then after that, he went back to the Columbia University for further education. He was working in a Presbyterian hospital. He got the Doctor of Science. I didn't know that Susan has a Doctor of Science. So Charles Drew got the Doctor of Science, that he got the degree in a Columbia University, further educated. During that time, he really took the work of his thesis and his dissertation, all of them related to blood separation, plasma separation, blood preservation, and transportation. He was thinking about the blood, how to move the blood into the massive situations, and as a massive program. So he was that was inspired by John Beatty. Remember that John Beatty? That was his work. He continued his work in the Columbia Hospital. That was in the Columbia University. His work. Then came in the World War II. Then London was bombed by Germany. There are mass casualties in London, and a lot of people needed blood, urgent need of blood. So the Britain requested help of the help of United States Navy and Army to help them to get the supply of blood. So blood is in demand. There was a huge need, a lot of casualties in England. So that is a huge problem at the time. It is a very underserved situation. Do you remember John Beatty is a mentor? He went back from Montreal back to England, and he became a director for the Royal College of Surgeons Laboratories. And then what he did was John Beatty did was he remembered his student Charles Drew. From then he called him up and say, "Can you help me for this project, Blood for Britain project?" So Charles Drew jumped into the occasion, and he changed the whole world of this blood chemistry. I tell you, what he did was, I didn't know that. Maybe Dr. Maya and Susan know a lot more than I do. But this is a blood. The storage of blood is a problem, is a challenging. The hours gets spoiled. Temperature is a lot of constraints for the regular blood. The whole blood cannot be. It has to be temperature sensitive, and its shelf life is very limited. And then place transportation. All of them are played a role for the whole blood. And you cannot give blood to everybody. You have to match the blood type. So what he came up with a brilliant idea. He took that. He separated the plasma from the blood. Plasma can be given to any type of blood type. I didn't know that, but that is a big jump. Then he created a dried plasma to transport easy. So he dried up the plasma. Actually, in the blood, I didn't know 55% is 55% is a plasma, 44% is this is a red blood cells, and then 1% white cells and the platelets and all those things. But out of the 55% of the plasma is 90% is water. So he took the water out, he dried the dried plasma and created an excellent storage situation. He changed the blood chemistry forever. Single-handedly, he became a scientist, and then he became a leader. He did the temperature maintenance, limited shelf life. He changed it into the plasma. Plasma could be given to anybody. He mix with the dried plasma with the distilled water, and he can give it to anybody. So that changed the whole scenario, and he really met the occasion. He became extremely popular in the U.S. Army, Navy. That was a very interesting transformation he did in the blood labs. Then American Red Cross blood bank. Then they asked him to start a blood bank. Mobile Blood Bank. He is the founding director for the American Red Cross Blood Bank. If you see today the blood banks from American Red Cross is because he's the father, he's the founder of that one, Dr. Charles Drew. He was U.S. Army and Navy requested him to be a medical director. He became a medical director for U.S. Army and Navy, and then he recruited mobile. He became a leader. He's a physician leader like Dr. Maya. He organized, not just a scientist, a great scientist, just like Dr. Margarita. He organized everything. He is a donate. He's a donor blood. He created a donor screening program and the collection of blood and transporting blood and then storing the blood, refrigeration, everything. He did a fantastic job in the leadership wise. He proved a very efficient administrator, not only a great scientist. He proved himself efficient administrator. U.S. Army and Navy saved him. He got the accolades, excellent accolades, but there is a dark story behind it. He could not donate his own blood to the institution he started it. His own blood, he could not give it to American Red Cross because segregation. They said that the blacks cannot be allowed to donate blood to the American Red Cross. That was a very, very sad story. In that one, he said that he raised his voice. He's a very principled. He's not a bitter guy. He was not a bitter person. He's always talks very. He said that is all blood runs in the blood is same in all veins. That's what he said. All the same blood runs in all veins. He said that, and he, in the protest, he resigned his job and then he moved to the Harvard University in Washington D.C. Then he joined in the Friedman Hospital, I think. And then he trained a number of next generation of black physicians. They became hundreds of physicians he trained. A lot of them became department chairmen. I know his friends and his students. Actually, I met several of them. That he really trained a number of black physicians to take care of and during that segregated period. So unfortunately, bad situation was. The unfortunate situation is at the age of 45, he was driving to attend a medical conference with his colleagues to the Tuskegee, Alabama. And Alabama, he was driving from Washington, D.C. to Tuskegee. On the way, he was sleepy and he met an accident. And he has some other conditions and he could not able to. The blood clot is not clotting the blood or something. I don't know the exact. There's a problem for him. And unfortunately, he died. His colleagues survived, but he died in the morning. It is at the age of 45. A brilliant doctor, a leader, died at the age of 45, who contributed to the medicine that he saved millions of lives. We could not able to save himself from this tragedy. So he died at the age of 45. So the same military that gave a directive to not to give blood to from a black community, black Americans, African Americans cannot give blood. They honored him. They regretted and honored him with the new ship called U.S. Navy gave him a cargo ship named USNS Charles Drew. It was a fantastic tribute to the U.S. Navy and military. Sea-Lift Command ship was named after him. That he was a pioneer in this one, and he's a short life. Then after that, a lot of schools were started on his name, medical schools, the high schools and the medical clinics, and the medical school. And then I'm a very fortunate to have a good connection with the Charles Drew Medical School in Los Angeles. That is the dean of the school, the president of Dr. David Carlisle is a good friend of mine. Is really a pioneer. He is also a very polite gentleman. As I tell you, that is one thing that I go to the goosebumps I get when I go to the Charles Drew Medical School. I attended a lot of their functions. I try to support with my friends, and really it's an honor to present him. So Dr. Maya may know a lot more the equity and the social determinants what that people go through. Thank you for watching. Okay, Dr. Maya, you can come and talk with about that. Yeah, you're championed, social determinants and the health equity. See that gentleman is Jenny, that people like him that paved the way for a lot of people like us and you and me and everybody else.
It's incredibly moving, and the stories like those are the stories that really inspire us to maintain that advocacy for patients, and for realizing even how, we are at an inflection in healthcare, and AI has the profound opportunity to tackle the most deeply entrenched systemic crisis that we have now in modern medicine, which is the diversity gap, especially in clinical research, and the access and bottleneck to patient care. And if we talk into the triad of helping patients, empower them with education so that they can meet us where we can really make a clinical impact in terms of clinical outcomes. So when we look at healthcare today, these two problems are inextricably linked, and we can see solutions come through. And so there are breakthroughs, like in the case of Dr. Drew, that when there are crises, when there are moments that are really challenging, and I feel so sad in terms of how much impact it could have continued to have
Yeah.
um, because of this car accident. But I think right now we have the opportunity to inspire other clinicians to continue to always have the patient at the center of everything that we do, and that we can use AI and use digital transformation as a tool to bring back the heart to medicine. And yes, through social determinants of health, through understanding the needs that the patient has, if it is the language, when we talk about certain medications, that they are really understanding what we're talking about. If it is really kind of what they have to do on their side, do it in a way that's motivational, culturally sensitive, and appropriate for their understanding. And lastly, when it comes to really understanding the community, we don't always talk about the healthcare burden on the caregiver. There's a lot of caregivers that really are struggling not only to take care of themselves, but the patients. So, I mean, we could go on, but I know we're running out of time.
Yeah.
But it has been
Susan,
such a pleasure to be here
yeah.
today on your podcast. Thank you so much.
Susan, you're a humanitarian. What do you think of the story? Inspires all the races, right? He is a kind of a inspiration for all the people in the humanity, the global thing. Just I want to take
No,
your opinion.
it was a wonderful story. And, I actually, where my mind was going was, thanks to that man, that amazing, amazing human, look where we are today with blood products. I mean, across our country, emergency medical services are using all kinds of, blood products, whole blood. We're getting blood on scene, saving lives in the field with blood. And so this is that man's work. It's where, so his legacy lives on. But Dr. Margarita, I agree with you. It's such a shame that his time was cut short, but his work is still with us, and then
Yeah,
some. So
yeah,
lots of
there
stuff.
is a kind of a doctor. Is inspiring people like Dr. Maya. She is the one taking the mantle of all those things. What do you think of AI and your future plans for the? What do you think? A lot of people, some doctors are very hesitant about the last question for a few minutes. A lot of doctors think AI is going to replace them. Lot of doctors and nurses. What is your take on that one, Doctor?
I really feel that the future of scientific innovation is being able to find that ideal patient that we're actually hoping to treat and cure. And if it's coming from the point of cell therapies and cancer, all the way to rare diseases, and making sure that they don't feel forgotten, and then ultimately dealing with incredibly challenging problems like obesity and diabetes. I think healthcare now is at a time of critical need of inspiration
Yeah.
and innovation, creativity, and lots of love, and really lots of love for what we do, and helping each other. And it really starts with ourselves, right? And so it starts with what you are doing, Ramana and Susan, and bringing the information to the people. And then for us to maintain that inspiration for curiosity and forever learning. So, although things are challenging today, we should not get discouraged or demoralized. Inspirations like Dr. Drew and yourselves, And then I am humbled that you even compare me to that, but I just would
No.
love to be a voice in making sure that we inspire everyone to partake in healthcare today.
We can't say anything more than that, Romana. I mean, with lots of love, Dr. Margarita, you just wrapped it all up so brilliantly. And,
Yeah,
I would like to close with so much love for you and your colleagues for having that curiosity, for getting outside of the walls of just this healthcare and using your brilliance in so many ways to bring that love to the people around the world. You are truly an example for physicians and practitioners of all across the spectrum to get some fresh air, use that creativity, and get out into these communities. Bring your genius, your zones of genius to the world. Patient care is wonderful and it's the heart, but there's a lot out there that you can do.
yeah. You're absolutely an honor for me, an honor and privilege, because it's a privilege in the sense that I really benefit from. I get the energy from people watching people like you to talking. That is the inspiration for this podcast. And thank you so much for joining with us. It is a truly an educational. You just gave a broad perspective of entire endocrinology and equity and the GLP-1. So you covered everything.
Thyroid love. We're gonna get some thyroid love.
When we all three get together, we'll have a margaritas together. And then, yes, right? Yeah, that's a good night, all of you. Thank you so much for joining me. Good night, all of you.
Have a great evening. Thank you.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it